Awesome. So hello, everyone. Hopefully you'll be able to join from the next session. My name is Sarah Isinga, and I'm the Manager of Patient Programs, Research and Advocacy here at Lymphoma Canada. And I'm pleased to welcome all of you to today's conference session on physical and emotional impacts of lymphoma treatment. The conference chair, Dr. Skrabek, will be giving the talk today. She is here with us. Her video is just off because of connectivity issues. Now, before I introduce the speaker, I just want to remind the audience that the session is being recorded. And at the end of the presentation, we'll leave a few minutes for questions. So please type your questions into the question and answer box that's at the bottom of your screen. And we'll try to answer as many questions as possible. So thank you very much for joining us today, Dr. Skrabek, and you can start your presentation whenever you're ready.
Thank you very much, Sarah. And again, I apologize for the lack of camera, but my computer that has a camera was, the sound was not good, so decided to sacrifice a video for better sound. And so I'm going to talk about impacts of treatment and hopefully discuss some thoughts on coping with these. And so just give me a second. And so we're going to outline common impacts of lymphoma treatment. Of course, we're not going to go through everything because it's difficult to predict everything that may potentially occur, and some things are much more common than others. We'll go over some common strategies for physical symptoms and concerns, as well as resources for coping with emotional impacts of lymphoma. I will say that I feel like this is less my area of expertise, but I like to try to direct patients to where they need to be directed. And so there's lots of different types of lymphoma treatment. I think you've likely learned that about at this conference. Regardless of lymphoma subtype, there's often chemotherapy options. There's an increasing number of oral or pill form options that are often targeted, so work in a different way than chemotherapy. Some patients will be treated with radiation, and transplant may also be a part of people's journey. So the impact of treatment is very much dependent on what type of treatment you receive, and the type of treatment that people get relates to their lymphoma subtype, as well as other medical issues. So things like heart function, history of infections, lung disease, as well as overall fitness level can influence the choice of therapy, as well as prior treatments and how well they worked will influence what the next treatment is going to be. Goals of therapy is also important when, particularly when patients are relapsing and there is no standard, meaning there is no one course that is sort of taken for everyone. Even when people are on the same treatment, impacts can be widely variable. And I think that this is something that I find, one of the things that Ian said in the prior session that struck me was that lots of times people don't know a lot about cancer. Like, they've had some people in their life with cancer. Often it's completely different than lymphoma, though, and the treatments, people come with a lot of misperceptions. And so hopefully, we can help with people's misperceptions and fears, but also prepare them for, the reality of side effects of treatment. And so what can you do as patient or family? Well, you're already doing it. You're attending this conference, so you're educating yourself. You're trying to learn more about your diagnosis and your treatment. And so that's a really good first step, because I think that, side effects will come, unfortunately. And when people anticipate them and know what to do, it tends to be very useful. So some additional things are, if you can take notes, although I find it's even better when a family member or friend takes notes, that way the patient can just focus on the discussion at hand. I do have patients that record encounters with me, and I am completely fine with that as long as I know about it. And so I think that that's something that you could always ask your physician. Studies actually show it's extremely beneficial to patients to record their encounters so they can go back and listen to it again. Often people will kind of either be going over their notes or going over in their mind, or maybe the handouts I've given them, and need to call back later to clarify. And I absolutely, feel that that is an important step. And so I often tell people to call the next day, because that first appointment or that appointment where we discuss treatment is so overwhelming. And, people need some time for things to think about, and often questions come to them later. The clinic nurses are a very valuable resource, and that's really what they're there for. And so on that note, use whatever resources you have available to you, whether they're, the handouts given by the Cancer Center, or, things that you find on Lymphoma Canada website. Often there's a lot of great links that Lymphoma Canada has. Nursing team, if there is pharmacy support, etc., use those resources. One other tip I'll say is keep a list of medication with you. I think that can be very helpful. And throughout your cancer journey, it's important to try to keep in touch with primary care, because there's other medical conditions that your lymphoma specialist is not as good at caring for, that need to be kept under control and monitored. And if they're not kept under control, for example, something like blood pressure issues or blood sugar issues, that can impact how you tolerate the treatments that you need for your lymphoma. So this is just a list of different lymphoma treatment options. So watch and wait is a treatment, and I'm going to talk about that briefly because I think there is a lot of impacts on patients from watch and wait. And so I do have a couple of slides to go over that. So there's traditional chemotherapy where we use drugs to kill lymphoma cells. Often those are intravenous treatments. And often those are where the side effect profiles that people think of when they think of cancer treatments, like hair loss, nausea, etc., that they tend to come from chemotherapy type drugs. Radiation therapy has its own side effects, and it tends to depend on really where in the body the radiation is delivered. And so if radiation is going to be part of your treatment, the radiation oncologist usually will go over what to expect depending on where the radiation is being delivered. Monoclonal antibodies, as well as targeted therapies, are increasingly used in all sorts of different types of lymphomas. And these are really more targeted than chemotherapy, so they have much different side effects. Infusion reactions are the most common one for the monoclonal antibodies, as well as some long-lasting low B cells, if they're an anti-B cell monoclonal. But there's also a lot of new side effects to targeted treatments that we weren't used to having before. So things like high blood pressure or abnormal heart rhythms. Transplant is often a part of people's lymphoma journeys, and this will have its own set of side effects, often brief, but very intensive. And so just to go over watch and wait. And I think this can have a lot of impact on patients because it's often not what they expect when they come to see the cancer specialist, to be told, okay, so you have this diagnosis and we recommend that we do nothing. Essentially, that's what people kind of hear. And there's lots of reasons for that recommendation. But it makes people nervous or uneasy, and that's totally normal. So I try to just help people understand, but sometimes, unfortunately, even when people themselves understand it, they're met with a lot of questions from family and friends, like, well, why wouldn't you treat your cancer? Because if you get on top of it sooner, that must make a difference, type thing, which, unfortunately, doesn't help when people are trying to cope with their own feelings about things. So the reason that we do watch and wait for indolent lymphomas is because multiple studies have shown no difference in lymphoma specific survival or overall survival, meaning that if we treat it earlier versus wait until the disease burden is such that it's starting to cause symptoms or some sort of concern on blood work or on exam, etc., we can still get a good effect regardless of when we intervene. And we can delay those treatment side effects that are going to impact people's lives. And so some people will never require treatment. And that's a really important point too, because we would be over treating that portion of patients who ultimately actually never needed it. So if you are told that the initial management is watch and wait, I think that there are things that you can do during that time period. One of them is just in general, try to be active, take care of yourself. I often encourage people to consider getting certain vaccinations during the watch and wait period. So before we introduce immunosuppressive medications, ask questions and talk about your concerns if things change with how you're feeling. And so just briefly, I'm just going to touch on what is chemotherapy. So this is the backbone of many cancer treatments, many lymphoma treatments. Most lymphomas, with the exception of CLL, are treated with chemotherapy initially. Some patients with CLL will go straight to targeted therapies. Chemotherapy works by damaging DNA in cells, and so it leads to cell death. And so by that way, it is not very specific to lymphoma cells. Those lymphoma cells, because they're growing, they tend to be affected by chemotherapies. The higher the dose that we give, the more the side effects. So that's why when we do an auto transplant, there's more side effects because it's a much higher dose of chemotherapy. Some of the common short-term side effects are listed in this slide. So hair loss. So not all of our chemotherapy regimens will cause hair loss. So our most commonly used regimen for indolent lymphomas, bendamustine, does not tend to cause hair loss, but many of our other regimens do. Mouse sores often are something that relates to sort of the intensity of the immune suppression. And so the more intense the chemotherapy, the more likely people are going to be to get mouse sores. These are something that sometimes can be very simply dealt with salt water or baking soda rinses, but other times people will need prescription mouthwashes. Nausea is a side effect of many chemotherapies. Some are more nauseating than others. I always say, like, if you're vomiting, I really feel like I'm not doing a good enough job, because there hopefully is ways to prevent that. And so really encourage people to, talk to their care team if they are nauseous to the point of vomiting. Fatigue is very common. It's common to be from lymphoma itself before we treat, and gets worse on treatment often, and is an issue after treatment as well. So we'll talk more about fatigue. Fever can be a side effect of treatment. And so we do usually recommend people to get a thermometer to be able to evaluate what their temperature is. And I'll talk more about fever and something called febrile neutropenia in a couple of slides. Low blood counts is a common side effect of chemotherapies, and that's because the cells in your bone marrow are actively dividing, and so they're very sensitive to the treatments that we use. So talking a little bit more about nausea, certain chemotherapies are more likely to cause this. Our goal really is to prevent vomiting for sure, and ideally prevent nausea as well, but I don't like to promise that. I want people to be able to maintain their hydration and their nutrition. People's sense of taste can be off, and so sometimes it can be hard to find the right thing to eat that doesn't put you off. One thing to keep in mind is that like pain medications, if you kind of imagine your nausea increasing and increasing like a hill, if you're getting close to the top of that hill, often it's too late and you may in fact vomit up the anti-nausea medication. So really when you're at that base of the hill is when you need to take the nausea medications so that they're more likely to be able to work. Some people need more than one anti-nauseant, and that's okay. As many as you need is what I say. So because, we just need to make things tolerable during this this time of treatment. Important to know that constipation can really contribute to nausea. And so this is often a problem because in CHOP, for example, constipation is very common. And then if people are using an anti-nauseant called ondansetron, that also causes constipation. And so, it can be a bit of a vicious cycle. And so, treating constipation is actually one way to sometimes improve nausea. Similarly, reflux is something that can contribute to nausea. And so again, if the medications you're given do not work, please call the clinic. With respect to blood counts, and so patients will see that we're doing their blood counts all the time. And this is because, this is something that's affected by treatment. And generally speaking, we want to make sure that the blood counts have recovered to a sufficient degree before we proceed with the next cycle of treatment. So what am I looking for in particular? So generally speaking, I'm not looking at the total white blood cell count. The total white blood cell count is really a bunch of different types of white blood cells added together. Doesn't really tell me as much as when I look just at the neutrophil count. The neutrophils really are the type of white count that we base our, is it okay to proceed with the next cycle of chemotherapy on? Whereas lymphocytes are going to be suppressed in people with lymphoma usually. And that is, not as much important to me. Anemia is common in people with lymphoma. It can be from the disease itself, if it's in the bone marrow, or it can be from almost like chemicals secreted by the disease, or it can be from the treatment, or all three. So some people even need transfusions. A lot of time people ask, should I take iron? Sometimes iron is beneficial if you are iron deficient, but often it's not iron deficiency anemia. And so in that case, iron will not help. It will just constipate you. So talk to your doctor about iron and if it will help if you're anemic, because, again, you don't want to take it if it's not going to be a benefit. The other blood count that we look at is platelets, and those help clot the blood. Certain chemotherapies, particularly one called gemcitabine, can really affect the platelet count, usually not to the point where people are having severe bleeding issue, but it can be influenced. And so what is febrile neutropenia? So often people get, handouts about febrile neutropenia, and the reason for that is it can be very serious if it's not treated properly. And so all chemotherapy can decrease the neutrophil count, and when the neutrophil count is low, people are at risk of getting bacteria that kind of takes over in their bloodstream. And that bacteria often just comes from normal things, like comes from your mouth, comes from your own bowel, comes from your own skin. So it's not necessarily an infection that you're getting from someone else. It's just an, normal bacteria that lives on you that, can cause a problem when your white count is very low, particularly if there's mouth sores present. And the reason we tell people to treat fever as a medical emergency is because you may be neutropenic and you need antibiotics promptly because you don't have those white cells to fight off the infection. Some people may be given a hormone that stimulates the bone marrow to make more neutrophils. And this is something called filgrastim or grastifil. And so certain chemotherapy regimens in lymphoma, we give this sort of, preventatively if there's a very high rate of febrile neutropenia, but other regimens have a lower rate of febrile neutropenia, don't need it up front. So infusion reactions are something that many people have to deal with. while getting lymphoma treatments. And that's because of the monoclonal antibodies like rituximab or obinutuzumab that we use. So these are great drugs. They work really good at killing B cells, but they're recognized as foreign by the body. And so people can have allergic reactions. These allergic reactions can come in a variant, and so they can be minor or they can be life-threatening. Most severe reactions can be prevented by giving pre-medications and giving the first infusion very slowly. And most people can get through getting the treatments they need, even if they have had reactions. So fatigue is kind of the very common symptom. It's often very difficult to kind of put your finger on one factor that's causing it. Treatment, will often make pre-existing fatigue worse, and people who have kind of the worst and most long-lasting chemotherapy fatigue are often people who come into treatment with issues with fatigue or exercise tolerance. This affects all aspects of quality of life. And one thing that's important to keep in mind is part of the fatigue is an actual change in the body composition. So people who are getting lymphoma treatments, generally, even if their weight hasn't changed a lot, often they've lost some muscle. And this can influence exercise capacity and can cause fatigue. And so it's hard to, there's a long list of things that we have to think of that could contribute to fatigue. So certain medications, although some of them, can't be stopped, can contribute to fatigue. Medical issues, so it's good to make sure that there isn't any thyroid issue, or sometimes if people have been on steroids for a really long time, their adrenal glands can not be working properly. So we always have to kind of go through making it's not those things. Sleep is a big issue. So studies have shown that people with lymphoma often have poor sleep. Partly maybe because of, the stress of the illness and, symptoms from the cancer. Maybe their sweats, maybe their pain, maybe it's distress related to your cancer. And, sometimes people just come to us and say, like, I've had poor sleep for years and now it's getting worse. And so it's, there's a variety of reasons, but really it's important to try to optimize that. Sometimes it is easier said than done, though, to be honest. Consistently, in all cancers, including lymphoma, and I think there was a session specifically about this, physical activity can have an impact on fatigue. And so regardless of the type of physical activity, there does tend to be some benefit. Most people can do things like walking, but important to talk to your care team about, if that's okay for you. I encourage people that come to their cancer diagnosis as very active people to try to maintain, maybe you won't do quite as much every day as you used to do, but that routine is important for physical and mental well-being. And it's amazing what some people do maintain. So I have had patients who are like, essentially elite athletes, personal trainers that run for 2 hours on the day of chemo. I do not expect that from people who have never done that before, obviously, but it's okay to maintain activity, and it's actually beneficial. So we already talked a little bit about brain fog or chemo brain. Sometimes it's called cancer and chemotherapy related cognitive changes. Whatever we call it, it is a symptom that can really influence people's cancer journey as well as their recovery. They find that their memory is poor, they can't concentrate on things, difficult to multitask, processing is slower, and just overall mental fatigue. As I mentioned earlier, this is not well studied, but there are some things that can help. Many of them are kind of self-care related, but also writing things down, take it easy on yourself, don't take on too many things at once, as well as some mental exercise. I find people are often very fearful of going back to work with brain fog or chemo brain, but at the same time, when they do start to gradually return to work, it can actually help because it's basically like, mental exercise. And so inquire about brain fog programs. We have one in Manitoba and patients seem to find it very helpful. Sometimes, it's all people need. Sometimes it's a good start at learning some new coping techniques. Neuropathy. So this is something that a variety of our chemotherapy drugs can cause. So vincristine, which is in CHOP, or vinblastine, which is in Hodgkin's lymphoma therapy, also cisplatin, and in some of the newer drugs as well, like brentuximab vedotin, all cause neuropathy. Usually what this is symmetric, so both sides of the body equally affected, starting in the hands and feet. Often it's, tingling that's intermittent to start, but then it can stick around and can progress. It's usually dose dependent, meaning the further you go on in chemotherapy, the worse it can get. If it's mild and not affecting people's functioning, we tend to just watch it. But if it gets more severe and starts to affect functioning, like you're dropping things, you're fumbling, etc., that's when we start having to adjust doses of our chemotherapy. There's no really clear preventative measures. Studies have looked at a number of things, and there may be some benefit of certain things. So they looked at essentially putting your hands and feet in cold water or cold mitts, etc. There's obviously some concern about making sure you don't get frostbite. But that may be of some modest benefit, but has been inconsistent. So it's not routinely recommended by cancer societies. Exercise also seems to have potentially some benefit, whether that is that it just helps people cope with the neuropathy because they're kind of, keeping their muscle mass up. I'm not sure, but there's certainly no harm. In terms of treatment, aside from adjusting dose, so really preventing it from getting severe, some people will need physical therapy to help recover. And if it's painful keeping you up at night, the medication that works best is probably duloxetine. So just a quick moment to talk about heart health as well. So particularly one of the drugs in CHOP can cause heart toxicity, more common in people that are older and have other risk factors for heart disease or a history of heart disease. This is dose related again. And so generally speaking, monitoring is recommended on treatment. Some people that are very high risk might require specific medications that can be protective. So we had some discussion in the prior chat about fertility and sexuality, and this is a very common concern for patients. Not one that people often bring up themselves. Sometimes they do, but I find that it's just so overwhelming at initial appointments that people forget to ask sometime. And so hopefully it's something, though, that most care providers are proactively bringing up. Chemotherapy agents do tend to be toxic to the ovaries, and so everybody has a limited number of oocytes or eggs, and you will lose some from chemotherapy. How important that is in terms of your how much that's going to matter really depends on the person, because it matters how close a person is to menopause, how much chemo they end up getting, how sensitive their ovaries are, and so it's really difficult to predict. Generally speaking, the regimens that we use for initial therapy, people will regain fertility after, but it's obviously not a guarantee. Some of the treatments, though, like transplant, are much more toxic to because they're higher dose chemotherapy, and therefore people are more likely to have issues down the road. There is also an influence on spermatogenesis as well as decreased testosterone, and so what I encourage is that people actually, if they have concerns about fertility, is that they see a fertility specialist before treatment. That is something I can usually arrange very quickly. So like I can usually get a referral within 24 hours or a day or two in Manitoba if needed. So sexual health is something that is impacts quality of life in patients with lymphoma. If you look at studies, it's often a concern of patients regardless of their age, and it's impacted by treatment. This is for a variety of reasons. So people are tired, there's physical changes, the emotional impact of cancer itself on them, as well as their relationship. And so the stress and distress. And directly, this also is from changes to estrogen and testosterone secretion. So this can be very distressing for people. And I find that they often, are reluctant to discuss it. The most common symptoms that we see are vaginal dryness, lack of desire, and erection and ejaculation issues. So when it comes to dealing with sexual recovery, this is a framework that I found to be helpful. You kind of have to think of all of the different causes of the problem, the biological causes, and help, deal with those. Potentially some patients may need to see hormone specialists or gynecology, but also deal with the psychological and interpersonal things that have been brought up by the diagnosis. And so, everything really has to be addressed. So weight loss is one of the B symptoms. And so often people will have weight loss, more common with aggressive lymphomas than indolent, and it can be very rapid. Hopefully this stabilizes on treatment. Some people will regain weight during treatment, but maybe not. I am always worried when people continue to lose weight on treatment. Because their chemotherapy tolerance and their sort of overall functional level and mobility really starts to get influenced because of all the loss of muscle. And so if the weight loss is not stabilizing, I really try hard to make sure that there isn't nausea or mouth sores or something like that isn't addressed, and refer to a dietitian. And so, I think that everyone should request that if they've had a rapid weight loss or if they have things that are limiting them from eating. And so, because dietitians can have lots of little tips on how to optimize your nutrition. And it's really the rapid weight loss that leads to a lot of loss of muscle. That means that people's strength and balance takes a long time to recover post-treatment. On the flip side, lymphoma is one of the cancers where we actually frequently see weight gain. It's not only weight gain during the treatment, but even after. So one study showed that 61% of patients gained an average of 10.4 pounds during the 18 months after their initial treatment. And that's likely due to a variety of reasons, but steroids are probably one of the culprits. To be honest, steroids really make people hungry and they change your metabolism. Also it's a stressful time. And so people, because of their emotions might change either their diet or their habits. They may do less physical activity. Partly they may be scared to, or they just don't feel good. So there's all sorts of things that contribute to weight gain. Again, when people bring up concerns about weight gain, I often do try to refer them to a dietitian. People need to be patient, even though the weight gain can happen very rapidly. Unfortunately, it, is less rapid to lose the weight, and really you want to lose weight slowly so you don't lose muscle. And I think it's also important to be mindful of, if you are really hungry. It's hard to say if you're really hungry with, because you're taking steroids. Just be mindful of what you're using to fill that hunger and try to make healthier choices to fill you up. We already talked a bit about impact on work. This could probably be a discussion in and of itself. And so lymphoma can impact work even pre-treatment, usually, hopefully, an indolent lymphoma, because people shouldn't have symptoms attributed to their cancer. Hopefully, they're able to continue working. Aggressive lymphoma, sometimes people have been unwell for a while before they get their diagnosis. And so it's important to let your doctor know like how long you've been off work for, awaiting a diagnosis, so we can, adjust the dates and, so you can get, whatever compensation you may be able to get earlier during treatment. Some people do continue to work, and I try not to discourage that. I just try to tell them realistically if I think it's going to be possible, depending on how many appointments are they going to have, how do I think they're going to feel, etc. So I try to support people, because some people, for financial reasons or mental health reasons, really want to continue to work. But many people will need about 6 months off work, and it's very variable when they're ready to return. So post-treatment, again, when you're ready to return, really depends on how much you're deconditioned and whether or not there's ongoing side effects that would interfere with return to work. People with aggressive lymphomas, if they're not in remission and need further therapy, then their return to work schedule can change multiple times, and that's really very stressful for people. Or they've gone back to work for a short period of time and they relapse. It's very stressful. With indolent lymphomas, our goal is to maintain quality of life. So hopefully people will be able to go back to their previous functions once we're done treating them. I think that most people really need a gradual return, because it's hard to just go back to the previous working hours and activities, and how that looks really is a discussion point between yourself, your physician, and your employer. Important, I always find people like leave forms for me, and that's fine, but like if I don't even know what their work involves, it's hard. So having that background, like, okay, I work as a like forklift operator, and these are my hours, and this is the kind of stuff I have to be able to lift, that really helps me to know, okay, what is realistic potentially. So post-treatment, so all of these physical and emotional impacts we've discussed will generally speaking decrease over time, but some will be long-lasting. People with severe functional impacts from their cancer itself or from the treatment might actually need rehab. And so what form that rehab takes is variable, but sometimes it will actually be a specialist in rehab medicine. And so people that have, for example, had spinal cord injury from their lymphoma, that is a common thing, as I would refer them to a rehab specialist. Physiotherapy can be very beneficial. Unfortunately, it's often not covered, and so people have to use private physiotherapy. But even if you can just get an exercise program, whether it's through an online thing or through the cancer center to start, I think that is very beneficial, because like I said, there's lots of muscle loss that comes from the disease itself and the treatment, and people to just get back their functional and exercise capacity and feel better, that needs to be regained. And so talking a little bit more about the emotional side, I will say that I am not an expert in this. And so I think I usually very early, if people are having difficulties coping emotionally, I like to use my colleagues that are better versed at giving people tools. And so all sorts of different emotions are common with a lymphoma diagnosis, and these are normal. So like Ian said earlier, like anxiety is normal. Being upset, being angry, feeling a loss, from having to miss out on things, that is normal. It's going to fluctuate throughout your treatment and throughout your lymphoma journey, but there are some times that we know are much higher in terms of emotional impact. Usually those are at the beginning, when all the diagnostic testing is being undergone. And with lymphoma, this takes longer than any other cancer to diagnose. And so that pre-diagnosis phase is really impacts people with lymphoma a lot, particularly, and it's actually even longer in young people than it is in the older population, where often cancer is suspected earlier on. Lots of different triggers for emotions, whether it be imaging or just appointments. Sometimes people tell me they feel nauseous just walking in the building, and that's because this is a stressful thing. Emotional side of cancer can impact every facet of your life, and so it can also influence some of the physical symptoms like fatigue, for example, as well as sleep issues. And so these things are really all interconnected. It is recommended that the care teams, whether it be the nurse or myself, sort of screen everyone for emotional impacts that are, to a point where intervention is needed. If you feel like you can't share this with your care provider at the cancer center, find someone. But there is a lot of resources here and a lot of people that are hopefully, I think, easy to talk to and have good ideas about how to deal with some of the emotional impacts. And so I encourage you to seek out the resources also for your family. So sometimes the patients themselves don't find that, they want or need our resources, but their family really does. And so some of the, we know that depression and anxiety are actually more common in family members of people with cancer too. So that's another important point, is it's okay for your family to use these resources, and it's in fact encouraged. Some people have a long-term relationship with primary care and find that they feel more comfortable talking about certain problems, whether they be emotional problems, sexual problems, with their primary care physician. And that's okay too. In fact, primary care probably treats psychiatric disorders like depression far more commonly than I do. And so there is emotional impact, which is very common, but then there's also psychiatric disorders like clinical depression or clinically significant anxiety. And there's very high rates of this in people with cancer. And this is not always identified and treated, I think, because maybe you have a perception that, well, you have cancer, you're supposed to be sad. No, I think that it's important that we figure out where people are on the spectrum, because there are things that we can do. And we know that untreated depression, untreated anxiety actually very much negatively impacts on cancer patients' long-term outcomes. So what can we do for psychiatric disorders? Medication really is the cornerstone. If you have clinical depression or clinical anxiety, generally that's needed. Some of the medications used for psychiatric disorders will interact usually with our anti-nauseants, but I try to let people know that that's not a barrier. There's lots of anti-nauseants that I can usually choose from to get around that. Having team-based care, collaborative care is really important for managing psychiatric disorders in patients with cancer. And so that means that, it's not just medications, but also psychotherapy, which is basically talk therapy involving a nurse, primary care, and mental health professionals when needed, has been shown to be more effective than sort of a single person approach. I think many people find support groups helpful, not even just for a psychiatric disorder, but just for dealing with the emotional impacts of cancer, period, to be able to share their experiences and find people that are going through similar ones. Some of the things that when I refer to psychosocial oncology, they often do are different behavioral interventions that help, but if there is a clinical depression or anxiety, often medication is needed. So hard to go over everything. So this is just a slide for me to remind you that Lymphoma Canada has lots of links. There's always the possibility of side effects that are worse than anticipated or completely unanticipated. But generally speaking, the common things are common, and hopefully there's resources that can help you learn how to manage Usually side effects are predictable with each cycle, meaning that like if you get really constipated from days 2 to 5, it's usually going to be that you get really constipated from days 2 to 5. So you can sort of like hopefully learn to like be more proactive with stool softeners or laxatives or something like that. So just to summarize, lots of short and long-term impacts of lymphoma itself in terms of emotional and physical with the treatments as well. I think that, it's ask questions about what to expect and ask questions about your experience, because I think that can help you cope maybe with it better. Might not be able to completely eliminate symptoms, but if we can kind of learn how to manage them and use whatever resources are available to you. Okay.
Awesome. Thank you for the talk, Pam. We have time for just really one quick patient question. And so this patient asks, if I can't do physical activities or work like they did before cancer treatment, what are some ways that they can accept the reality of their situation and the physical activities that they can do now?
I see. So if you cannot, yeah. So that is, well, that's a hard question. So I think that that happens, and so sometimes there is permanent changes to a person's body where they're unable to get back to the functioning the way they used to before. How do you cope with that loss? I think is variable for each person, and I think that the sharing your feelings is important because it's devastating to have not be able to do the physical things that you used to be able to do. And for many people, they take a lot of joy in their work, and it's devastating to not be able to go back. If you can, I would encourage to try to see if there's been a significant change in functional status, rehab specialist. And so this is new in Manitoba, but we do have a physician who specializes in cancer rehab. And I have found that there are all sorts of things that she suggests that I would personally never think of. And so, I think that your lymphoma provider is good at treating lymphoma, but not as good at sort of the rehab expertise. And so, unfortunately, people push and and advocate for yourself, because there may be things that can really help you learn to cope with your new normal.
Awesome. That's some great advice. So I hope that helps our patient. So thank you everyone for joining this session today. And thank you, Pam, for your excellent presentation. Please stay tuned for the next session on nutrition for lymphoma and CLL patients. Thank you.